Good afternoon, everyone, and welcome to our webinar organized by Xavant Technology on the topic of Behind the Mask. Insights from neuromuscular block monitoring experts saying trust is not enough. Behind the Mask is our series. So I take my mask off so that you see who I am. My name is Stephanie Perez. I'm the moderator of this session today, and I am honored to introduce you to our esteemed speakers who are the expert in this field. So both of the speakers will talk about the safe administration and reversal of neuromuscular block drugs in safe environment in the daily practice, and also about the new guidelines. Our first speaker is Dr. Guy Cammu. He is anesthesiologist in the anesthesia department and critical care in a 900-bedded general hospital in Aalst, which is located close to Brussels in the beautiful Belgium. Dr. Cammu is one of the cardiac anesthesiologists working in the OR as well as in the ICU unit, and he has his scientific interest within the neuromuscular block monitoring and transmission, and also on the reversal agents. And he had the privilege a few years ago to be involved in the phase study following on the development of Sugammadex. Our second speaker is Dr. Hugo Carvalho. He's anesthesiologist working in the hospital in Bruges, Saint-Juan, and he is associate member or consultant of the research for the unity of the hospital in Brussels. And moreover, he's also member of the scientific forum of the ESAIC. Also, Dr. Carvalho, is having interest in the perioperative neuromuscular monitoring and transmission, and this was a topic of his PhD thesis. Dr. Carvalho is also having focus on the research in the application of the artificial intelligence, and not only on the purpose of the improvement of accuracy in the neuromuscular monitoring, but also in the prediction of the perioperative neuromuscular behavior. So we hope we will engage with all of you within this webinar and encourage you to participate through your questions, thoughts, and comments. Please use therefore the Q&A button, and then we will review them and we'll comment on that after the presentation of Dr. Cammu and Dr. Carvalho at the end. And yeah, with this said, I will hand over to Dr. Cammu so that you can start your presentation. Thank you very much and enjoy.
Dear all, I'm very grateful to the organizers of this webcast, the Xavant crew, and especially Stephanie Perez and Roche van Rensburg. My presentation deals with safe administration and reversal of neuromuscular blocking drugs in daily practice. And it finds its origin in the recently published guidelines in Europe and the United States of America. And indeed, there are a lot of logos on top of this first slide, this title slide, but you will later understand what the meaning of this is. Just have a look whether everything is okay, because mine does not work.
No worries, Dr. Cammu.
Okay.
Meanwhile, if you
That's
want,
better,
we
I think.
can. Okay, it's working now. Okay, perfect.
Everything clear?
Yes, clear.
Great.
Thank you.
We go ahead.
Yes, please.
My conflicts of interest are that I am a consultant of Merck, Sharp and Dohme, and that I am an unpaid member of the scientific advisory board of Senzyme, which is a company that develops a neuromuscular transmission monitor. Okay, this is not because of chauvinism, but let us start where I live and where I practice. In my little country, Belgium, the safety guidelines for practicing anesthesia are mentioning in the revision of the text in 2019, are mentioning in section 5, monitoring equipment, minimal standards. You have to use a monitor of neuromuscular function. You should have that at every place where general anesthesia is provided. Now, this is a general statement that means that a qualitative as well as a quantitative monitor may be used, meaning a tough count versus a tough ratio. Now, much more prominent were the 2021 recommendations from the Association of Anesthetists in the United Kingdom. For those who are interested, really interested, the reference is on top of the slide, stating that, first of all, every operating theater or location where neuromuscular blocking drugs are used should be equipped with a quantitative neuromuscular monitoring device. And adequate recovery means that the TOF ratio should be higher than 0.9, and it should not only be demonstrated on the screen of your monitor, but it should be documented in your anesthesia record before the patient is awakening and before the patient is extubated. Second point, the ulnar nerve is the most useful site for neuromuscular monitoring. And the guidelines of the UK say that there are alternative options. You have the accelerommyography, you have the electromyography, you have compressomyography, you have kinemyography things, but you have also alternative sites to monitor, such as the fascial or the tibial nerve and the muscles which are lying behind that. Now, a fascial nerve monitoring used is the first recommendation, the first guideline that is mentioning already that limitation. The risk of residual paralysis is 5 times greater, and it's best to revert to ulnar nerve stimulation at the end of surgery. So the risk for residual paralysis when you use the fascial nerve monitoring is high, much higher than you measure at the wrists. Great. Now, why is that? This is because the corrugator supercilii muscle, just look down to the slide. This is because the corrugator supercilii muscle is a quite resistant muscle, almost comparable with the diaphragm. And we all know that the problem of residual paralysis lies with the pharyngeal muscles, not the diaphragm. So everything has to do with neuromuscular blocking agent sensitivity of different muscle groups. That means the acetylcholine receptor per neuromuscular end plate, the configuration of the neuromuscular end plate between, or the difference between that, between different muscle groups. So resistance means that you need 2 or 3 times the neuromuscular blocking agent dose for the same depth of block. This has nothing to do with onset or offset time of neuromuscular blocking agents. That is an issue that is more related to cardiac output. Why I'm telling you this is because of, in literature, this is sometimes very, with a high degree of complexity defined in textbooks and in papers. So be aware of the fact there are resistant muscles with a low sensitivity, for example, diaphragm, for example, the corrugator supercilii muscle. There are muscles which have high sensitivity to neuromuscular blocking agents, such as the pharyngeal muscles, and indeed the masseter muscle. But wait before you draw conclusions. The masseter muscle is much more sensitive and could thus be an excellent muscle to be compared with the pharyngeal ones. However, its stimulation, it's often accompanied by direct muscle stimulation. And that is not surprisingly. Looking, for example, at this picture, where stimulation electrodes and muscle contraction recording are on the shortest distance you may ever notice. Even with specially designed sensors, and you see that on top of the slide, the right side, specially designed sensor. This is one from Draeger. The facial nerve monitoring remains a cumbersome issue, so try to avoid that. The foot is another alternative recording site. Plantar flexion is observed when stimulating the posterior tibial nerve, whereas toe lifting is the result of stimulating the peroneal nerve. Now, the fifth image is right underside of the slide. You see the toe lifting that is the resulting of stimulating the peroneal nerve, but ideally the electrodes need to be placed much higher towards the knee than in this picture. Electrode devices are not designed for such a distance between knee and foot. They're simply not that long, the difference between electrodes and between the recording system, the recording piezoelectric crystal. So, ladies and gentlemen, the guidelines are right. Let us stick to the hand. Let us stick to the hand to monitor. Indeed, we have nowadays excellent equipment to monitor the neuromuscular block. We have in this picture the StimPot. We have in this picture the TOF scan. We have electromyography monitors, excellent ones, the StimPot, the Petrograph, the Twitch View. The advantage of EMG monitors compared with other monitoring techniques, acceleromyography, kinemyography, the TOF-CUF, for example, is that EMG monitors, well, such as others as well, are standalone monitors and can easily be transferred from one operating room to another one, from one theater to another one location to another one. But especially the EMG monitors have the big advantage that when the arms are tucked under the surgical drapes, tucked along the body, and no thumb access is really ideal. The thumb access is not, the thumb cannot move freely. Then the EMG monitor has the big advantage that it can give an adequate result when you measure, because it does not measure the mechanical result, but the electrical result of stimulating a nerve and the result of that being muscle contraction. Apart from that, no preload is needed. There is no need for normalization. There was the big advantage of the single-use electrosensors during COVID period, because everyone was concerned about cross-contamination of that nasty virus, that nasty beast being Corona. But now everything around Corona is behind us and nobody bothers or seems to bother anymore. The only thing we now say is that those single-use electrosensors, they are proprietary, single-use, and they often cost more than 10 euros each per patient, per measuring moment, per measuring site, per measuring one patient. That is a disadvantage. It's cost price. Okay, at the end of 2022, the European Society of Anesthesiology and Intensive Care published the guidelines on the perioperative use of neuromuscular blockade. Thomas Vogel, he was the president of the committee and the leading author of that paper. And let's go through those recommendations. R1, recommendation 1, we recommend the European Society states, not unimportantly, that it is still a practice, a clinical practice, a guideline to use a muscle relaxant to facilitate tracheal intubation. And, well, a bit connected to that, if you do not use a muscle relaxant to intubate the tracheas of your patient, you may cause pharyngeal and laryngeal injury because of that. Recommendation 3, when you do a rapid sequence induction, you use rocuronium 3 to 4 times the ED95, about 1 milligram per kilogram. And yes, indeed, European Society still mentions the use of succinylcholine, 1 milligram per kilogram, when doing rapid sequence induction. Recommendation 4, there may be circumstances in which you think that it is best to deepen the neuromuscular blockade during surgery because of increasing the surgical conditions, optimizing the surgical conditions. But there is insufficient evidence to recommend a standard deep neuromuscular blockade during laparoscopy, thoracoscopy, or whatever, to reduce some post-operative outcome issues. Just a moment. I got a cold, a bit of a flu during my night shift, so excuses for that. Recommendation 6, obviously, a bit what we awaited, use the ulnar nerve, use quantitative neuromuscular monitoring. Recommendation 7 and 8 is linked to each other. It's quite shocking. It says that Sugammadex is there to antagonize a deep, a moderate, but a shallow neuromuscular block as well. R8, recommendation 8 continues with stating that actually the room, the space, the indication of using neostigmine is only limited to those conditions where spontaneous recovery has become or has a level of a TOF ratio of 0.2 or higher, measured with a quantitative neuromuscular transmission monitor. So this means, ladies and gentlemen, that this frequently used slide, it was once created by François Donati, and I think I used it 20, 30 times during several lectures, and not only me. Many authors did use this over the years. They relied upon this slide, but applying the new guidelines to this slide is not valid anymore. The new guidelines suggest neostigmine is only useful when the TOF count is 4 and the TOF ratio recovered to more than 0.2. So forget about what is on the major part of this table. Good. The European Journal of Anesthesiology and Intensive Care paper shows in, for example, this table, that when the TOF ratio is around 0.2, a considerable, well, below 0.2, a considerable and unacceptable number of patients does not reach a safe extubation threshold after being given neostigmine, often in high doses. Look at the 70 mics per kilogram. So you have to end your TOF monitor has to show a TOF ratio of 0.2 or higher when you want to rely on neostigmine as a reversal agent. Another table shows that when neostigmine is compared with Sugammadex, more efficient reversal of neuromuscular blockade with less residual paralysis is achieved after Sugammadex than when neostigmine is used. Now, Sugammadex for some months in the major part of Europe still on patent and more expensive than neostigmine. However, enough evidence is there that it provides faster, more reliable, and more complete reversal of neuromuscular blockade than neostigmine at any level of block. Next one, quantitative neuromuscular transmission monitoring is superior to qualitative monitoring. So a TOF ratio instead of a TOF count. And or the use of clinical signs such as hand lift, hand grip, tilting of the legs, and so on. Good, let's go to the United States. In the beginning of 2023, the United States as well came with guidelines, and this time published in Anesthesiology, and differing to, well, some extent for some details from the European Society guidelines. They start with saying that you should not rely on clinical assessment for judging, for assessing a neuromuscular blockade. You should use a quantitative monitor which is superior to qualitative assessment to avoid residual neuromuscular blockade. Residual recommendation 3 concerning residual blockade, we know that. Recommendation 4, we know that. Recommendation 5, they are very confident. They are very strict. They do not leave an opening. They say, do not use eye muscles for neuromuscular monitoring. That's, well, for sure, a quote, for sure, a statement, a recommendation that comes from Søren Bro, who is very much against using eye muscles, fascial nerve stimulation to assess residual neuromuscular blockade. Okay, in recommendation 6 is stated that neostigmine should only be used when the TOF ratio is greater than 0.4. Now remember the 0.2 in European Journal publication. And recommendation 8, US guidelines, is an interesting one. Recommendation 8 leaves an opening for those clinicians using benzyl isoquinolines and only use qualitative neuromuscular transmission monitoring. This recommendation states that extubation should be performed when the TOF count is 4 and not earlier than 10 minutes after neostigmine administration. This recommendation is still there because in a lot of small hospitals worldwide, not only in the middle of the United States of America, worldwide, not every operating room has a quantitative neuromuscular transmission monitor. And perhaps Sugammadex is not always available over there at any time. Good. The US guidelines started in their recommendation 1 with telling to the reader that the major flows that may occur after clinical assessment of the neuromuscular blockade alone without monitoring. Now, this is own work from many years ago, 2006, showing the very low sensitivity of several clinical tests with regard to the capability of diagnosing and reassuring a TOF ratio of 4.9. And the US guidelines continue with recommendation 2, with the importance, stressing the importance of quantitative monitoring. Now, this recommendation is for sure based on a large number of papers, but typically the position paper by Glenn Murphy, you see on this slide, a very important example of this. Look at this slide a bit in detail, and about all of the respiratory variables, upper part during transportation of the patient, lower part during their stay in the post-anesthesia care unit. A very significant difference was found in favor of those who received quantitative monitoring compared with qualitative measures. And all is a consequence, the very right side of right part of the slide, all of this is a consequence of the fact that the TOF ratio at the end of surgery was significantly higher when quantitative neuromuscular transmission monitoring was used compared with an ordinary TOF count. Look at the spread, look at the outliers in the conventional monitoring group. Finally, it is of importance to notice that even when using Sugammadex, neuromuscular transmission monitoring remains the Achilles heel of avoiding residual paralysis. Look at these tremendously important findings by Kotake. And congratulations to Kotake. He is a Japanese anesthetist, actually a bit discussing, actually a bit criticizing the practice in his own country. Japan is a typical example of a country where routine clinical care does not normally involve the use of a neuromuscular transmission monitoring to guide neuromuscular blockade, to guide antagonism. So he performed a study in which he compared, well, patients who had neostigmine, patients who spontaneously recovered, patients who had Sugammadex, but without monitoring, fixed doses of neostigmine, fixed doses of Sugammadex, or spontaneous recovery. And he found 4% of his patients who received Sugammadex having residual paralysis. That's a huge incidence. That's a huge number. Everyone does not like to read this number. This is unacceptable. Although some of these anesthetists use quite impressive doses of Sugammadex. There are clinically important outcome differences between neostigmine versus Sugammadex. Brandon Togioka some months ago published a nice overview of how to optimize reversal of neuromuscular block by choosing between Sugammadex and or neostigmine. Now, the results were fairly consistent across upper part observational studies, lower part randomized control trials. Sugammadex provided a protective effect, with the majority of studies, look at the most right side of the slide in red, showing a 20 to 30% lower relative odds of post-operative pulmonary complications for patients that received Sugammadex. The stronger study, data from a general population, all outcomes in favor of Sugammadex, pulmonary complications, risk of pneumonia, risk of respiratory failure, meaning reintubation in the post-anesthesia care unit, were all in favor of Sugammadex. And after the stronger study came the still stronger study. The still stronger study, a study with the same population as the stronger study, but only looking at the patients at risk, being those ones with ASA physical status 3 or 4, undergoing intrathoracic or intra-abdominal surgery. Quite logical, those surgeries with the highest incidence and the highest risk of EOPCs. Patients with an age of 80 years or older, or undergoing surgery lasting longer than 2 hours. And all these data, all these odds ratios were again in favor of Sugammadex. They were independently associated with reduced odds of development of a composite of major post-operative pulmonary complications in favor of Sugammadex, compared with those patients who received neostigmine. Now, I would like to end with citing nobody else than Sorin Bruhl, and I'm not going to give my own version of it. I'm just going to quote it. Sorin Bruhl and Aaron Kopman say that some clinicians who have practiced anesthesia for decades without using quantitative monitoring may feel that the guidelines, these guidelines, the European ones, the UK ones, the US ones, these guidelines are an intrusion, and they may resent being told to practice the art and science of anesthesia. However, the guidelines represent the evidence-based medicine, ladies and gentlemen, and the prejudices of 20 or 30 years ago are now much less convincing. Let us try to imagine where medicine would be today had we not accepted the progress afforded by new drugs, techniques, or technologies. So far, Sorin Bruhl and Aaron Kopman. And I just added the right part of the slide. If we would still be using pancuronium without neuromuscular transmission monitoring, and, by the way, defining residual blockade as a TOF ratio below 0.7, that was the threshold when Burke and Vivi Mogensen in 1997 wrote this paper. If this would still all be the case, the risk for post-op pulmonary complications would be, look at the slide, about 60% in octogenarians, and about 40% of patients who are 50, 60 years old. I hope that in 2023, we are all convinced that this is not the level of care we want to offer to our patients. Thank you so much for listening, and enjoy the further program. Thank you very much.
Thank you very much, Dr. Cammu, and also for addressing all about the professional responsibilities on the patient safety by monitoring the residual monitoring blocks by the moment of the extubation. So very important presentation for the ones that are not aware yet of the new guidelines. Let me just pull up some questions to the audience before we continue with the next presentation of Dr. Hugo Carvalho. And as I said, we will then address all the other questions at the end of the presentation.
I'll then start my presentation. Can you see the screen?
Yes, we do. Thank you.
Okay, perfect. I'll also like to start by thanking you for the opportunity to give my thoughts on the subject, for which is much appreciated. I would like also to thank you all for listening to me. I have no important conflicts of interest to declare, and I guess Dr. Cammu has already addressed a lot of the most important European or United States recommendations, so I will try to stay out of that. Of course, there's always a bit of overlap, so instead I will try to put my focus on a bit more like statistics and demographics of monitoring usage, as well as some human factors and also some myths in neuromuscular management. So what is this all about? When we talk about the safe administration of neuromuscular blockers, we are putting our focus a bit on the post-operative parts. Of course, there's a component of intraoperative management of neuromuscular blockers, but most of the complications arising from the usage of neuromuscular blockers have to do with its post-operative effects, namely post-operative pulmonary complications. As you might imagine, post-operative pulmonary complications are a rather broad composite of complications. So, and they are influenced by a lot of elements, such as the type of surgery, patient factors such as obesity, as well as, for example, ventilation strategies in the perioperative period. So it is difficult to put out a study that analyzes or excludes the single effect of neuromuscular blocking agents. So as you might see from this picture, there have been a lot of studies about this topic. What we do know is that, in fact, neuromuscular blockers, if not appropriately measured, can lead to residual weakness, muscular weakness after an operation, which then is a clear predisposing factor for post-operative pulmonary complications. So monitoring is essential, and is then on monitoring that I will try to focus myself on. So how do the clinicians do in general? From the surveys that are available in literature, not such a nice picture arises actually. So anesthesiologists, depending on the country, tend to use neuromuscular blocking agents a lot without any kind of monitoring. Depending on the country, this might go up to 90% of the surveyed populations. Up to 19% never uses any kind of monitoring and believes actually that clinical intuition and experience alone is sufficient. Also, anesthesiologists that don't use any monitoring and standardly reverse patients are also a mere 18%. Anesthesiologists also express some moderate confidence on the results of what neuromuscular monitors present, and the most commonly reported factor that leads to a bit of distrust in monitors are actually inaccurate measurements or artifacts. However, most anesthesiologists think that neuromuscular monitors are worth their price. So you get, in fact, what you pay for. So as I said before, lots of anesthesiologists report seeing a lot of artifacts, but the question arises that are these actually artifacts or some misinterpretations? And an example of a possible misinterpretation I present here in these pictures, which is the presence of TOF ratios above 100% in monitors that use movement-dependent sensors, such as acceleromyography or kinemyography, for example. This kind of artifacts is actually known, these super unitary TOF ratios. However, if anesthesiologists are not aware of them, they tend to interpret this as an error, and most of them actually tend to discard or distrust the monitor and don't use it anymore. So this just reiterates a bit the importance of education and training with monitors in order to combat this sort of cynicism that tends to appear when using neuromuscular monitors. However, true artifacts do exist, and in fact, no monitor is immune. However, software updates tend to improve the reliability of the monitors for this purpose. So this is something that tends to get better with the usage of the monitor and with the release of updates. Just like in any other subfield of anesthesiology, neuromuscular monitoring has had also its go with artificial intelligence. And I'm just not going to go too deep into it, but just to mention that artificial intelligence or machine learning techniques have been applied to detect anomalies both in the TOF ratio as well as in the general evolution of the TOF ratio throughout an operation. And it will not be surprising that these techniques get incorporated in future monitors as a way to improve the consistency of the results and also to reduce the cynicism of clinicians store these kind of monitors. So as we see, there is a disconnect between the availability of monitors throughout the operation rooms and the effective use of these monitors by anesthesiologists. So this disconnect needs to be addressed. And this is something that the latest guidelines from the European Society of Anesthesiology Intensive Care, as well as from the ASA in the United States, recognize. And in fact, they state that adoption of monitoring does represent a significant change for a lot of clinicians that have grown not using this monitor. So this tends to be transmitted from peer to peer and tends also to be exacerbated by the fact that loads of the post-operative pulmonary complications, we do not, as anesthesiologists, we do not tend to see them. Most of these occur after discharge from the post-operative anesthesia care unit. So this tends to compound this problem of anesthesiologists that never use any monitor, but also don't see any complications. For the purpose of educating clinicians, there are a lot of resources. The producers of the different such as this one online. So all of these resources can be used for the purpose of education clinicians. So it's less work that one has to go through in order to implement these kind of quality improvement projects. However, implementation is not easy, and there have been a few studies about this. A pretty known one is one of Dr. Todd, in which he tried to implement electromyographic neuromuscular monitoring in his department, and then tried to also to evaluate throughout the years if there was a significant reduction of postoperative residual paralysis. And although, in fact, this is a sustained education process, the good news is that what he observed was, in fact, a consistent reduction of the postoperative residual curarization in the post-anesthesia care units. They started with an approximate incidence of 30%, and throughout the years, it has stayed approximately around 15%. Our first presenter, Dr. Cammu, has had its own go at the topic, and he actually demonstrated similar results. It came from the high incidence of residual paralysis, and then it plateaued just above 10%. And what he states is actually quite important because it helps also to understand a bit the dynamic of the problem. It takes more than just putting a monitor in the operating room. It takes also a sustained education effort, frequent appraisals, frequent reassessments of monitoring. And despite of all these efforts, there are still people that are not so enthusiastic in adapting monitoring, and that's just parts, just like in any other field. That's part, and that compounds the problem, but it's part of it. And this is shown by the fact that postoperative residual paralysis is not reduced to zero. Nevertheless, we do have the tools to reduce it to zero. Another positive message is is the answer to the question of we are moving in the right direction. And the answer is, in fact, yes. This is part of a meta-analysis that my research group conducted, in which we plot the incidences of residual paralysis throughout the years. And what we can see is that for all types of monitors, this incidence has been reducing throughout the years. This might sound a bit surprising. So why is it not only for quantitative, but also to qualitative monitors or no monitoring at all? There are different factors that can explain this. The types of drugs that we have been using throughout time are different. Long-acting drugs such as pancuronium are not used anymore. And not only that, but we also have more and better monitors. And there has also been an increased awareness to the problematic of pulmonary complications, residual paralysis, and all of this helps to move this residual paralysis incidence in the right direction. What's also important from this picture to understand is that the incidences with qualitative monitoring versus qualitative or no monitoring are quite different, and statistically significantly different. So quantitative monitoring leads to less residual paralysis when compared to both qualitative or no monitoring at all. So now I'm just going to run quickly and practically through over a few pitfalls that clinicians tend to base themselves on, to base their neuromuscular monitoring on, but actually tend to lead to the wrong conclusions. And the first one I actually already addressed a little bit, and is the fact that clinicians or anesthesiologists tend never to see the true complications of residual paralysis. What an anesthesiologist might tend to think as the biggest complication of residual paralysis might be a reintubation, but actually these sort of events are rather rare. Most of the more subtle complications actually happen after discharge from the postoperative anesthesia care unit. Something that we can, in fact, objectivate is that patients tend to be longer after post-anesthesia care units, and this is their discharge is delayed. Another common pitfall, which Dr. Cammu has also touched, is the fact that some clinicians tend to base themselves on clinical signs to decide whether or not the patient is adequate to be extubated. This is quite frequent, but again, a big pitfall. For example, a normal tidal volume is possible between TOF ratios of 10 and 30%. And just because a patient is able to generate enough diaphragmatic force to produce a normal tidal volume does not mean that he will be able to maintain a patent airway when the tube is pulled out. So there's a bit of a disconnect between what clinicians think is adequate and what is actually adequate. Another also frequent, I will not put it as an excuse, but as an argument to extubate a patient without monitoring, is clinicians that state that their last dose of rocuronium, for example, has been given a long time ago. In the graph below is an example of a patient that belonged to a study that we conducted, a practical study in which we just set to measure if the TOF ratios that we normally measure during clinical practice are similar to what is predicted by the best pharmacokinetic and pharmacodynamic models, and in this case only for rocuronium. And here we have an example of a patient that at first sight does not have any elements that we think that might lead to a prolonged neuromuscular block. But what we see is that there's a big disconnect between what is predicted and what is actually the reality. Of course, not all patients are like this, but in approximately 200 patients that we studied, what we see that all in all, there tends to be a big disconnect between what is predicted and what is the reality, and sometimes up to 1 hour, 1.5 hours. And these are the models that we get taught when we're studying anesthesia, and that define common variables that we know, such as half time of a drug. These are static variables, but they tend to disregard a bit what is the intraoperative dynamics. So basically the conclusion is there is too much variability. If we don't measure, we really don't know where we are. Another common pitfall is unmonitored antagonization. Dr. Cammu has basically touched this also. Neostig mean needs to be given at the right moment, depending on the guidelines, at a tough ratio more than 20 or 40%. Otherwise, there is a big variability in what would be the expected return to a normal tough ratio. So just giving Neostig mean at the end of an operation without measuring the tough ratio is also not adequate. Sugammadex, Dr. Cammu also touched this topic. Residual paralysis is still possible if Sugammadex is given, and we don't know exactly at what depth of block the patient is. Certain patients, such as the elderly and obese, are actually at particular risk for getting recurarized after Sugammadex. So it's something we need to focus on. Also, and this is very important, Sugammadex is not always the most cost-effective option. However, selective use of Sugammadex is. And below, I just show you a study that has been recently published this month in Anesthesia and Analgesia, in which the main author, also the main author of the ASA Guidelines, set out to see if they would antagonize a patient based on the guidelines and quantitative neuromuscular monitoring, as opposed of just giving Sugammadex to everybody. What would be the cost difference? And actually what they observe is that there were savings of approximately 43% by just targeted antagonization instead of just using Sugammadex for every patient. So as you see, this might also cumulatively lead to some cost saving. So the bottom line is residual neuromuscular block is both prevalent and, importantly, a silent entity. We don't tend to see it on the immediate postoperative period. There are a lot of neuromuscular management myths, and these tend to be propagated peer-to-peer. So educational efforts are primordial to reduce this phenomenon. And the only way to consistently and reliably exclude residual paralysis is just by using quantitative monitors. As a matter of curiosity, I'm also going to discuss a study that has been published in the beginning of this year concerning the use of remifentanil for intubation. So the question also arises, so if neuromuscular blocking agents have all these possible side effects of residual paralysis, postoperative pulmonary complications, what about avoiding them? And this was basically the premise of this study. They set out to see if just intubating with remifentanil versus neuromuscular blockers would lead to a greater success or non-inferior success at the first intubation, and also to an intubation with similar adverse events. And what I actually saw was that remifentanil was actually inferior in both success on the first intubation attempt and as well as an intubation without adverse events. This did not reach what they defined as the non-inferiority margin. But as we later replied to the editor, and as well as also editorials have argued, there were a few limitations with this study. One of them was, for example, that patients were intubated 30 to 60 seconds after giving rocuronium, which tends to be based on a normal pharmacokinetic and pharmacodynamics, tends to be quite insufficient. An optimal onset of rocuronium tends to be between 60 to 90 seconds. And in this study, no monitoring was used during intubation. So there's really no possibility to see if the patients were adequately paralyzed whenever rocuronium was given. So possibly this effect is bigger, but it just also stands to show that even in such big scale studies published in big impact journals, not always the optimal monitoring is employed in neuromuscular monitoring. I'm also going to briefly touch geriatrics, as these patients are frequently encountered in our clinics. Postoperative cognitive dysfunction has received an increasing attention in the last years, and the Safe Brain Initiative is a non-profit organization, has put out a set of recommendations in order to optimize cognitive outcomes for geriatric patients. And one of those relates to the avoidance of anticholinergic medication. And this has a direct connect with neuromuscular management, because whenever we use neostigmine, we tend to counteract its vagotonic effects with an anticholinergic medication that crosses the blood-brain barrier, and this is atropine. So this is not exactly a direct recommendation of Sugammadex for all patients, and especially geriatric patients, but it's naturally something that we need to take into account. And since I touched geriatrics, I might as well also touch a bit of pediatrics. Just as in adults, the use of neuromuscular monitoring in children is quite sparse. The representative reports that have taken place show that only 30 to 40% of clinicians actually use the monitoring. And impressive is that the more experience they have, also the less monitoring they use. And as well, the more Sugammadex they use, the less the monitoring. So it's a bit of sort of reinforcement of the common pitfalls. What has also been observed is that high dose of neuromuscular blocking agents tend to lead to high postoperative pulmonary complications. The younger the patient, the shorter the surgery, and the higher the ASA grade, the higher these postoperative pulmonary complications tend to be. Also important to refer is that the younger the patient, and especially in neonates, the normal pharmacokinetic and pharmacodynamics of normal neuromuscular blockers tend to be way outside what we are able to model. And for example, rocuronium on a high intubating dose can have a duration of up to 19 hours in a neonate. So that once again states the importance of monitoring. Neostigmine tends to be avoided by pediatric anesthesiologists because, of course, it has a bit of a bradycardic potential. Sugammadex has been linked a bit also to bradycardia, especially in the early clinical studies. However, the incidence has later been shown not to be, for sure, not greater than neostigmine. And although, and it's still only approved for children over 2 years old, recent reports that show that it is frequently used off-label. And in fact, some clinical studies have for the approval of this drug for pediatric patients under 2 years are actually ongoing. Very important also, and this relates to the use of Sugammadex in women in fertile age that are using an oral contraception. In these patients, if Sugammadex is used, because it also tends to encapsulate the steroidal part that is given with the oral contraception, there is the potential that these women get pregnant within the first week after receiving Sugammadex. However, up to 40% of anesthesiologists never discuss this with the patient. Finally, in terms of anaphylaxis, there does not seem to be a different incidence rate when compared to adults. So to finish, I'm coincidentally also gonna leave you with a quote from an editorial by Soler Brule on the use of and misuse of neuromuscular blockade in children, but actually that translates a bit to the entire neuromuscular monitoring field. And it just states that if you offer the lazy thing as okay, then people are just gonna take the lazy one, unless you show that doing the extra work, in this case, monitoring, has an indication. And the conclusion is actually exactly the same as Dr. Cammu, so I'll be repeating myself. There is a huge body of evidence now that shows that optimal neuromuscular management, antagonization, and so forth tends to lead to better outcomes. So there is an argument why you should take that extra 30 to 60 seconds to measure a TOF ratio. Thank you.
Thank you very much, Dr. Carvalho, for your presentation. And I see that we are in a continuous education and skill development need, so that the physician and clinicians should well be updated on the guidelines and on the new monitoring technologies. So we are just on time. So it's 6 p.m. We are maybe running a bit over the time if you allow. So we would like to address 2-3 questions. And before we do that, I would like to mention that we are very honored to have Dr. Weigel here attending this webinar. He is the co-chair of the ASA task, and I had the pleasure to meet him last year at the ASA Congress. So thank you very much, Dr. Weigel, for attending this webinar. So let me go to a few questions. So rather Dr. Carvalho or Cammu, you can respond to this. So one question is, what is the incidence rate of residual neuroblock when using succinylcholine, and how important is it to monitor?
Should I?
Go ahead, Hugo.
Well, I was just going to state that the incidence of residual block with succinylcholine tends to be underdiagnosed because it also tends to be under-monitored. In fact, with succinylcholine, unless you have a phase 2 block, you don't see a fading in the TOF ratio. You tend just to see a reduction on the twitch height percentage. So you normally have to measure before what the twitch height is, and then see how much it has been reduced. So in fact, like accurate rates for the incidence of residual paralysis with succinylcholine, as far as I know, in a representative manner, are actually unknown. But I assume also they're also a bit underdiagnosed.
Okay, thank you. Let's read another question asking, can we use the stimulator in spinal cord stimulation?
That, as far as I'm aware, there are different monitors.
Mm-hmm.
Well, obviously, it's definitely. I mean, it's not interchangeable. I mean, it's totally different mechanism. So there's no problem with measuring. And just adding to the previous question, the problem with succinylcholine is that the measurement, as Hugo told perfectly, is a subjective measurement. Of course, that's because of the mechanism succinylcholine work compared to the non-depolarizing neuromuscular blocking agents. The issue is that the importance of measuring when you use succinylcholine is that you have to be aware of those patients who have plasma cholinesterase deficiency, pseudo-cholinesterase deficiency. That's not that infrequently encountered in our population. So I would just add one thing. If you use succinylcholine, it is even much more important to assess the neuromuscular block with monitoring compared with the other neuromuscular relaxants we have. Do not forget that in clinical practice.
Sure. Thank you, Dr. Cammu. Let's see another question. How is it possible that recurarization can occur with Sugammadex?
If you allow me, I'm just going, I have seen this question, and if you allow me, Hugo, to
Yes.
just go to a part of a presentation that I gave earlier. How is that possible? Actually, the same question is that why should we still monitor when we give Sugammadex? Why would we not routinely use a standard dose of Sugammadex in all of our patients? I mean, it's all the same question. If you think that recurarization cannot occur after Sugammadex, this is wrong. I mean, there are several case reports, typically with vecuronium and Sugammadex, less after rocuronium and Sugammadex, but yet there are those case reports. And they are all relying on the same errors people make. If you think as a clinician that you can give Sugammadex without monitoring your neuromuscular blockade, you can do that in, I think, at least I think, in two different ways. Or you give in every patient 100 or 200 or 300 milligrams of Sugammadex, or you give everyone a 4 milligram per kilogram, means the deep block reversal. That's one manner of thinking wrongly. The second manner of thinking is that you put dose Sugammadex on a total molar base. That means that the total molar clearance of all administered rocuronium, whether it is all complexed or renally excreted or hepatically metabolized, or the free rocuronium within body compartments, it requires 4 milligram, 3.57 or about that, 3.6 milligrams to be exact, Sugammadex to encapsulate, to antagonize 1 milligram of rocuronium. So that's the molar base of antagonizing rocuronium by Sugammadex. Okay. Now let's go to that first example. You give a standard dose of Sugammadex to your patients. There are a lot of studies meanwhile, and this is one example that show that when doing that, you have an unacceptable degree and an acceptable level of residual paralysis after Sugammadex. This is, for example, a study of Ledowski. There are other ones as well. Amit Raval, quite recently, 2 years ago, in a double paper in the Journal of Clinical Anesthesia, showed that when you looked at the 9 studies that are available that report residual neuromuscular blockade incidence after Sugammadex in patients with, for example, a deep neuromuscular block, that when you do not monitor, that, for example, 5 minutes after administering Sugammadex in patients who have a deep block, when you do not monitor, still 36% of your patients are residually paralyzed. Now, when you molarly antagonize, when you antagonize with Sugammadex on a molar-based dose, yeah, that's a strange practice, because every drug, I think, should be based or should be given only if necessary. And that dosing scheme would always, well, significantly exceed the required amount. So that's a costly affair. And Iwasaki 2 years ago showed that when you use, and Hugo showed a similar paper, when you use intraoperative neuromuscular transmission monitoring, you can tremendously reduce the reversal dose of Sugammadex compared when you give it as such on a routine dose based. So it's just no good practice, and recurarization can occur because of redistribution when you underdose your Sugammadex as an antagonist of your residual of your neuromuscular blocking agent, and residual paralysis can occur in the recovery ward afterwards, on the regular ward, and so on and so on. These cases are reported. That's not a weakness of Sugammadex, it's a weakness of the performer who use it. So everything has to do with the margin of safety. I mean, you may not forget that when we use a threshold of 0.9 or even 0.95 to extubate the tracheas of our patients, look at this figure, you still have the iceberg effect. A lot of receptors are still blocked with neuromuscular blocking agents. So we are at the edge of safety. So when you underdose Sugammadex, you are playing with the chance of that walking on that edge of safety. That's just what I wanted to show you.
Fantastic. That's amazing how you can explain all this in your presentation and now again. So thank you very much. Just last question quickly before we finish. So there is a important question, so that's why I wanted to put it before we finish. Someone is saying we are not currently using Objective NMT monitoring in our hospital. What advice can you give me to encourage the hospital to invest in this technology?
Go ahead, Hugo.
I think you can actually base this on evidence. You can make a business case effectively with the available evidence. One of the papers you can perfectly use is the one that I've shown you. I don't know exactly how it works in your country, but I have been recently working before I came back to Belgium in another hospital, and how I could make the business case for the hospital to invest in the monitors were just by showing how much Sugammadex was being used in a blind manner, and what were the potential saving costs, or by actually just using targeted antagonization. And that, in my case, was enough. So if you also factor in the reduction of postoperative pulmonary complications and how much this potentially also costs intensive care admissions, the extra days that a patient has to stay in the hospital because he just developed a pneumonia aspiration, for example, these are also highly theoretical, but in the meantime, there's a huge body of evidence to support the arguments that you will be making on the cost-saving potential of just adopting a neuromuscular monitor. And again, you have EMG and you have also EMG and AMG. EMG tends to work with consumables, but you also have quantitative monitors not based in consumables. So you can make this like a single acquisition cost, not something that is a recurring cost. So in that sense, there's definitely a business case for convincing. And of course, that might perhaps be also an extra effort that you might be having to undertake, is just that the educational effort. As I guess, like as you have seen from the study of Dr. Cammu, it just does not take. It is not enough just to place a monitor in the operating room. You need again to involve your colleagues in the project, show them how to use them, and actually make them aware of all of the potential improvement of care that you will be doing by just making quantitative monitoring.
Thank you very much, Dr. Carvalho, for your advices and also from your personal experience, which is important to share, because I know that there are many clinicians, they are not able to get that monitors into the hospital. So the recommendation should also be valid, that the hospital will have it ready for the anesthesiologist if they want to use it. So that should be also considered as such. So I don't know if Dr. Cammu, you want to add something on this, or?
Not really, Stephanie. First of all, you gave a great lecture, Hugo. Congratulations for that. Indeed, you may not underestimate the cost of for example, one unwanted ICU admission because of a post-op pneumonia. What that costs in the ICU. As a net cost, but also an emotional pay for the patient and his families or her families, that does not outweigh the costs of monitoring devices. Second, that's not obviously something that probably depends from country to country, but for example, in Belgium, when something is in guidelines, the way between, or the gap between guidelines and coming into law, I mean, a real law that can be used in medical legal issues, is not that long, is not that far, is not that great, that gap. I mean, the most important thing is obviously that we use NMT monitoring and interpret it for the safety of our patients and the quality of the medical practice we perform. But you may not forget that medical legal issues may be behind the corner as well. So as well for those things, hospitals, departments need to invest in NMT monitoring and need to use it. Just a thing I wanted to add.
Thank you very much also, Dr. Cammu, because this is exactly what we need to hear and to mention in this webinar, and hopefully we will be able to talk about it more and more, and that we can spread this message around the globe. So hopefully we will be achieving our goal, which is eliminate the residual neuromuscular block, at least hopefully before. But our goal is to have this eliminated by 2025. So we need to work a lot on the awareness and also re-education. So that's why we are always trying to make as much as we can on this. Also the different companies, they try to do the webinars and to be present in all these educational workshops and also on our websites. And so thank you very much, both of you, for your excellent presentations. And to the audience also, thank you very much. And we exceeded a bit the time, so I know everybody is probably now up to leave, but thank you very much also for your time. And if you have any questions, you have my email address with this invitation, so you can come back to me and I will then forward it to the faculty if needed. I will send out a survey form to the audience so that we will learn if the webinar can be improved. That is always a way to improve from our side. So your comments and replies are welcome. So thank you very much again, and I wish you a pleasant evening and hope to talk to you and see you again soon.
Thank you, Stephanie. Thank you, Rosh, and thank you, Hugo.
Thank you, everyone.
Thank you. Very interesting.
Very much.
Thank you.
Bye-bye, everyone.
Bye, everyone.
Bye-bye.
Bye. Bye-bye. Good evening.
Bye. Good evening.